Hi everyone, how have you all been? It's been a while since we've been on your screens, but we're back with another season of our Friday live streams. This time in support of our upcoming virtual conference, Radiopedia 2023. We've picked out some of the best lectures from our collection, and myself and fellow Radiopedia colleague Amanda will be your hosts. You can watch live with us and chat with us in the chat box, or watch on catch up for a few days after the live stream has ended. Now, speaking of Radiopedia 2023, details of the conference have just been released. It's running from the 24th through to the 28th of July of this year, and registration is now open. Now, as before, there are many different registration options. You may be in one of the free access countries listed on our website, and if you do, please go ahead and put your application in now. You may wish to purchase an all-access pass, and as well as the conference, that gets you our lecture collections and learning pathways. That's a lot of content. And of course, you may wish to register just for the conference itself, and there are tiered and concession rates available, and all the details are on our website. And just as with our previous conferences, we are bringing you the highest quality speakers, the most beautifully crafted videos, crispy audio, English captions for all lectures, and lots of review questions for you to test your knowledge on. So go ahead and check out the registration options now. Now, something brand new for this year, and many of you have demanded it, and we want as many of you to be involved as possible. We are accepting abstracts for posters, and of course we had to put our own Radiopedia brand of magic on it, so we're calling them our posters. Now, the deadline to submit your abstract is the 28th of February, so that's not far away, so get your thinking caps on and make sure you don't miss that deadline. All the details of what you need to do are on our website. Something important to point out is all published R posters will receive a DOI, a certificate, and a chance to win an award. So we're looking forward to seeing all of your beautiful creations. Let's get to this week's lecture. This one is by Tabby Kennedy. Tabby is a neuroradiologist in Madison in the USA, and this lecture is titled Knowing Where to Look, Clinical Localizing Signs and the Brain. I think you'll really enjoy the way in which Tabby links up imaging neuroanatomy with specific symptoms and signs of neurologic disease. So enjoy this lecture and do drop any comments you have in the chat.
Hi, my name is Tabby Kennedy. I'm a professor of radiology at the University of Wisconsin, and I'm honored to speak to you today on knowing where to look, clinical localizing signs, and the brain. I do not have any conflicts of interest, but I do have some acknowledgments. Some diagrams used for this presentation were funded by a core curriculum fund grant sponsored by the American Society of Head and Neck Radiology. I'd like to thank my friend and colleague, Dr. Terry Mangian, who is a neurologist who I get to learn from every week during a clinical correlation session that we co-teach at the University of Wisconsin, and to Dr. Jeremy Height, who is a neurointerventionalist at Stanford, who has graciously given me permission to use a graphic that he's created that displays strokes in different vascular territories. I have two primary objectives for my talk today. I'm hoping that by the end, you're going to be able to localize regions of the brain responsible for producing characteristic vocal neurologic deficits in specific vascular territories in acute stroke patients, and to identify some cortical signs that are localized to the left and right hemisphere. Many pathologic processes affect the central nervous system in characteristic anatomic locations, producing predictable neurologic exam findings. An understanding of some common neurologic presentations can help the neuroradiologist target their search pattern and to hone in on pathology that may otherwise go undetected. When the stroke code pager goes off, we know to anticipate a set of CT images in rapid succession to evaluate three primary questions. Is there hemorrhage? Are there signs of acute stroke? And what vascular territory is involved? We'll typically be talking to the stroke neurologist as the non-contrast CT images are coming over, and we'll ask, what are the patient's symptoms? It's critical for me as a neuroradiologist to understand the basics of neurolocalization so that I can efficiently focus my attention on the region of the brain and vasculature that I suspect is most likely affected. Let's consider this patient's presentation. This is a man in his 60s who presents with acute right upper and lower extremity weakness and dysarthria. We remember that motor fibers originate within the primary motor cortex within the precentral gyrus, which is the most posterior gyrus of the frontal lobe. These are topographically organized based on the homunculus, with the lower extremity located towards the midline and the mouth located far lateral, with the upper extremity interposed between. Those fibers leave the cortex and travel through the subcortical white matter and pass through the posterior limb of the internal capsule as the corticospinal tract. Within the brainstem, those fibers decussate and descend within the contralateral spinal cord. This helps us to understand why, if a patient has acute right motor weakness, we'll initially focus our attention on the left hemisphere. As neuroradiologists, we're certainly interested in localizing areas of stroke within specific vascular territories, and we can see here that the anterior and middle cerebral arteries are both responsible for supplying the homunculus. While patients with anterior cerebral artery territory infarcts tend to have isolated lower extremity weakness, patients with MCA territory infarcts can have both upper and lower extremity involvement, since the lower extremity fibers have to travel through the MCA territory as they make their way to the internal capsule. In our patient, who has right body weakness and dysarthria, those findings could be caused by an MCA distribution infarct or potentially by a much smaller infarct in the internal capsule. Making this distinction can have significant vascular implications, and that allow one to differentiate between suspected large vessel occlusion or small vessel occlusion. So are there clinical clues that can help us distinguish between these two categories of patients? In this patient, we also find out that the patient has word-finding difficulty and gaze deviation in addition to the weakness. The presence of these additional signs are extremely helpful in localization, both of which are cortical signs. Cortical signs are those higher-level cognitive functional tasks that are localized to the cortex and are often present in the setting of a large vessel occlusion. An example of a cortical sign found in the left hemisphere is language, and when one has a problem with language, we typically describe that as aphasia, which comes in several varieties. Gaze deviation can also be considered a cortical sign, and one typically sees eyes deviated towards the side of the hemisphere affected by stroke. The presence of word-finding difficulty and leftward gaze deviation, in addition to the extremity weakness in this patient, all point to a large vessel MCA occlusion. Understanding the localization now can help us focus our attention on the region of the brain that we suspect as being abnormal. The majority of large vessel occlusions involve the middle cerebral artery, so it makes sense for us to focus on this vessel first. The first segment of the MCA is referred to as the M1 segment, and that's the horizontal segment before it divides. The middle cerebral artery has some variability related to its branching pattern that ranges from a single trunk, a bifurcation, trifurcation, and quadrifurcation. The most common is the bifurcation, with branches referred to as the superior and inferior divisions. There is also some variability related to the relative vascular contributions of the superior and inferior divisions. The inferior dominance is seen slightly more often than the superior and inferior dominance. Codominance of the superior and inferior division is the least frequent pattern. When the inferior division is dominant, it supplies the temporal lobe and parietal lobe, with the superior division responsible for vascular supply to the frontal lobe in that situation. Now we're ready to look at some images of our patient. Our stroke code examination that includes a non-contrast head CT followed by a CT perfusion and CT angiogram of the head and neck includes over 4,000 images. So the history in this case is going to allow me to focus my attention on the left hemisphere and on the anterior circulation. On these non-contrast images of the head, we can see that there's no evidence of hemorrhage, and I don't see any areas of cytotoxic edema. Perfusion can be incredibly helpful to signify a region of potential ischemia, particularly when the non-contrast scan is normal. In this case, we see a region of abnormal perfusion in the left MCA territory, as was clinically suspected, with a mismatch volume of 70 mLs. As predicted by the clinical presentation, as well as by the perfusion data, the CT angiogram shows a filling defect within the left M1 segment of the middle cerebral artery. Notice here the leftward gaze deviation, as was seen on physical exam. One of the other important things that we also want to identify is to evaluate a potential source for stroke, and in this case we can see a significant non-calcified atherosclerotic plaque in the left internal carotid artery, just distal to the bifurcation. Because the mismatch volume and the M1 occlusion was present, this patient was deemed a candidate for thrombectomy and was taken to the angio suite. We can see restoration of flow within the left internal carotid artery and middle cerebral artery following thrombectomy. Remarkably, this patient only had a small area of completed infarct on DWI. Let's take a look at this companion case. This patient is a man in his 50s who presents with acute onset of right upper extremity weakness, which began 4 hours prior to presentation. A stroke was suspected and a stroke code was activated. Here you can see on this non-contrast head CT looks pretty normal. On DWI, we can see that there's a region of diffusion restriction in the left precentral gyrus, in the region of the hand knob. Without knowing the clinical information and knowing where to look, one could easily pass over the small area of infarct seen only on one slice of this MR examination. Now, technically, this is a cortical infarct, but this cortical infarct is a lot different than the previous example. While cortical, this is not the result of a large vessel occlusion, but rather the result of a small vessel occlusion, and the treatment is certainly different. Knowing some basics of cortical anatomy in this case was crucial to be able to identify the abnormality. There are a few clues to help to identify the central sulcus on CT and MRI. The superior frontal sulcus terminates within the precentral sulcus. The sulcus just posterior to the precentral sulcus should be the central sulcus, which extends towards the midline. The pars marginalis, or pars bracket sign, should be found immediately posterior to the central sulcus. The precentral gyrus is found just in front of the central sulcus. The hand knob has a characteristic U-shaped configuration near the vertex, which corresponds to the region of the upper extremity on the homunculus. Let's take a look at this next patient. This next patient is a man in his 70s who presents with acute left lower extremity weakness. Now, isolated lower extremity weakness, we're really going to be thinking about where that falls on the homunculus. And we know that that is towards the midline, and that's supplied by the anterior cerebral artery. So we're really going to be focusing our attention on that right ACA territory, and on this non-contrast head CT, we don't see any evidence of hemorrhage or areas of cytotoxic edema. When we take a look at the perfusion, we can see this characteristic prolongation within that right ACA territory on perfusion, and an explanation. We can see that there's a small focal filling defect within a branch of the right ACA. Let's take a look at this companion case. This patient is a man in his 40s, also with weakness. Now, this patient has both arm and leg and face weakness, but this patient's language function was intact. So for both the upper and lower extremities to be affected as a result of a cortical infarct, based on where they are on the homunculus, one would expect a very large MCA territory infarct. But if that were the case, we would also expect to see some other findings, like aphasia or sensory deficits, which were all intact in this case. So where else should we look that could cause this constellation of findings? We have to look at the internal capsule, which is a conduit for the corticospinal tract fibers from the cortex to the brainstem. Here, on this non-con head CT, we don't see any evidence of hemorrhage, but we do see potentially a small area of low attenuation within that left internal capsule, which was confirmed on DWI. So here we can see that this is as a result of a small vessel infarct in a very eloquent part of the brain that results in hemibody weakness. What is important to know is that both motor and sensory symptoms can result from a large vessel and small vessel infarct. However, the presence of cortical signs can often really help you favor a large vessel over a small vessel territory occlusion. The main cortical signs that we think about are language and attention. In the vast majority of individuals, the left hemisphere is dominant for language, and attention is typically localized to the right hemisphere. When we hear terms that refer to abnormal speech comprehension, repetition, and naming, this suggests an aphasia. While there are a number of types of aphasias, the two most commonly encountered are expressive aphasia and receptive aphasia, or Broca's aphasia and Wernicke's aphasia. Broca's aphasia is an expressive aphasia characterized by non-fluent, scarce production of speech with poor articulation in the form of short sentences with only a few words. Patients often can't get words out. They know what words they want to say, but they feel frustrated. Let's listen to an example. This is a 19-year-old who previously had a stroke.
And what happened to you?
Stroke.
You had a stroke last year.
Yes.
And what happened? Can you remember what happened?
School and English class.
Okay.
And I book and I read it aloud. But I can't because stroke.
So where is Broca's area? I find Broca's area by pulling down a sagittal series, in this case, the sagittal flare. I find the lateral sulcus, which is right here, and find this triangular-shaped gyrus, which is called the pars triangularis. Just posterior to the pars triangularis is the pars opercularis, right here. Anterior to the pars triangularis is the pars orbitalis. Broca's area refers to the pars triangularis and the pars opercularis of the dominant, typically left inferior frontal gyrus. In receptive or Wernicke's aphasia, individuals express words fluently, but the words often don't really make any sense. Lesions involving Wernicke's area lead to speech errors known as phonemic paraphasic errors, in which the phonemes, consonant or vowel sounds distinguishing one word from a different word, are chosen incorrectly. These errors are cardinal features of Wernicke's aphasia. Let's listen to an example.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck, for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
So where is Wernicke's area? I find Wernicke's area on that same sagittal series by following the lateral sulcus posteriorly. So let's do that. So here's our lateral sulcus. We're going to follow it posteriorly. And Wernicke's area, outlined in green, refers to that dominant left hemispheric posterior perisylvian region, right in this area, including that posterior superior temporal gyrus, as well as the supramarginal gyrus. Now, the angular gyrus is located just posterior to that supramarginal gyrus. Now, with these two examples firmly in our mind, let's take a look at a few clinical cases of patients presenting with aphasia. The next case is a man in his 50s who presents with right-sided weakness and fragmentary speech. Now, with fragmentary speech, we're thinking that this patient has an abnormality localized to Broca's area. Based on the symptoms and presentation, this likely involves that left anterior inferior frontal lobe as a result of an occlusion of the superior division of the MCA. On the non-contrast head CT, we don't see any evidence of hemorrhage, but we do see maybe some subtle blurring of the gray-white matter differentiation involving that left anterior frontal lobe. On perfusion, we can see a small area of perfusion deficit within that left anterior inferior frontal lobe. Now, based on the location of this perfusion abnormality, we're certainly worried about a superior division MCA occlusion. And when we look at the CT angiogram, we can see that there is this focal cutoff that corresponds to left MCA superior division occlusion. Now, this patient had a mismatched volume of 27 mLs, and because this was affecting Broca's area, this patient was deemed a candidate for thrombectomy. And we can see that after thrombectomy, the patient had restoration of flow related to this occlusion in that superior division. The patient did have a small core infarct, but it would have been larger had the patient not underwent thrombectomy. This next patient is a man in his 70s with fluent aphasia and a visual field cut. Now, because the patient had a fluent aphasia, we're certainly worried about an inferior division occlusion. Now, on the non-contrast head CT, we don't see any evidence of hemorrhage, and there's no evidence of cytotoxic edema. When we scroll down and take a look at the sylvian fissure, we can see that there is this hyperdense vessel within that inferior division of the MCA, which corresponds to that expected perfusion deficit within that inferior division territory. On the CT angiogram, we can see this abrupt cutoff of that inferior division of the middle cerebral artery. This patient was also deemed a candidate for thrombectomy, and we can see that we've got this vascular cutoff of that inferior division, which was restored after thrombectomy. Our next patient is a man in his 40s with hypertension, diabetes, and high cholesterol, who presents with acute onset of left upper and lower extremity weakness and neglect. So what does the presence of neglect tell us? The syndrome of hemispatial neglect is characterized by reduced awareness of stimuli on one side of space, even though there may be no sensory loss. Neglect often occurs following unilateral brain damage, particularly of the right hemisphere. Although it can be caused by various different pathologic conditions, it's often related to an acute infarct. Patients with neglect often fail to acknowledge items on their contralesional side and tend to items toward the same side as their brain damage, their ipsilesional side. Their neglect may be so profound that they may fail to acknowledge their own contralesional body parts. And some patients fail to use their contralesional limbs even if they have no weakness, so-called motor neglect. Importantly, many neglect patients may be unaware that they have these problems, which is referred to as anosognosia, sometimes denying that there is anything wrong with their perception or control of movement. So how do we test for neglect? One can do a number of tests that include a line cancellation test, like we see on this slide, where you ask a patient to bisect all of the lines on a paper, and the patient will preferentially attend to the lines on the right part of the paper and neglect the lines on the left. Likewise, you can ask them to draw a clock face, and they will likely only draw half of the clock or draw half of a picture. Cortical damage involving the right inferior parietal lobule or nearby temporal parietal junction has classically been implicated in causing neglect. It's also become apparent, however, that the syndrome may also follow focal lesions of the inferior parietal lobule. So when we take a look at the imaging of our patient, our 40-year-old male who comes in with left upper and lower extremity weakness and neglect, we're really going to be focusing our attention on the right hemisphere. Now, we don't see any evidence of intracranial hemorrhage on these select CT images. And as we scroll down, we're looking to see, do we have any areas of gray-white matter differentiation blurring? And we can still see that gray-white matter differentiation preserved within the frontal lobe and the parietal lobe. And when we scroll down inferiorly, we can see that there's some subtle blurring here involving that inferior temporal lobe. And when we take a look at that right MCA, we can see that we've got a dense MCA sign. So we're certainly worried about an MCA M1 occlusion. Now, this patient was transferred to our university hospital after receiving TPA, which ultimately did not change their symptoms. And we can see on MRI that we've got this large wedge-shaped region of diffusion restriction within that right MCA distribution with a matched perfusion deficit. So what branch is likely occluded? Well, this is a classic distribution of an M1 occlusion. When we take a look at the MRA, though, we can see that the entire right internal carotid artery is actually missing. And so why does this patient not have an anterior cerebral artery distribution infarct? Well, we can see that the circle of Willis, that ACOM, is intact, which is preserving flow within that right anterior cerebral artery territory. Let's take a look at this next case. This is a man who was driving, who did not see a car coming from the left, and he presents as a trauma patient. So when we take a look at these three images from the patient's non-contrast head CT, we can see that there was no evidence of hemorrhage, but we do see a wedge-shaped region of cytotoxic edema within that right parietal lobe. It is possible that the patient's symptoms in part could be related to a visual deficit, but why did the patient not recognize that they couldn't see? This patient has neglect. So when we take a look at the MRI, we can see that the patient has diffusion restriction corresponding to that area that we noticed on CT. And when we take a look at the cervical vasculature, we can identify that the patient has this focal area of critical stenosis within the right internal carotid artery just distal to the bifurcation. So our next patient is a man in his 40s who presents with sudden onset visual disturbance. Now, he presented with complaints that he was missing the right half of his vision in each eye, and he kind of felt off, like he was drunk. He had some neck pain the week before and a headache, and he presents to the hospital and was found to have a right homonymous hemianopia. If we take a look at the schematic of our visual pathway, we can focus our attention on the region of the optic radiations within the left hemisphere. And when we take a look at the non-contrast head CT, we can see that there is this focal area of low attenuation within the left occipital lobe. So we're suspecting that this patient has a posterior cerebral artery distribution infarction. Now, when we take a look at our perfusion images, we identify that there is a focal region of core infarct that's corresponding to that region of low attenuation that we suspected on the non-contrast head CT with a larger area of tissue at risk. When we take a look at our CT angiogram, we can see this focal cutoff, this focal occlusion of that left P2 segment of the posterior cerebral artery. And looking at the CT angiogram of the neck, we can identify the potential underlying source. We've got this focal area of luminal narrowing, likely related to an underlying dissection of that left vertebral artery. So this patient had a left occipital lobe infarct related to a vertebral artery dissection. Let's take a look at this companion case. This is a man in his 70s with sudden onset of right homonymous superior quadrantanopia that was painless. Now, we remember that the retinotopic organization is maintained along the optic pathway, and in the occipital lobe, the superior retinal fibers terminate within the lingual gyrus below the calcarine fissure, and the inferior retinal fibers terminate within the cuneus above the calcarine fissure. So in this patient with the superior quadrantanopia, we're going to be focusing our attention on the left lingual gyrus, and we can see in this patient that they've got a very subtle region of diffusion restriction within that left lingual gyrus here. Now, on our FLAIR image, we can see that we've got this focal area of FLAIR signal hyperintensity that's corresponding to a subacute infarct within that left posterior cerebral artery distribution. So similar to the last case, we really want to interrogate why did this patient have a stroke within that left occipital lobe. So we're going to be focusing our attention on the vertebral arteries within the neck. Now, when we take a look at the vertebral arteries, we can see that we have flow within the vertebral arteries, but they're relatively small in caliber. We really don't see any posterior circulation vasculature on our TRIX acquisition here. So no flow within the basilar artery and nothing more distal to that. So what is causing this? Well, when we take a look at our time of flight images, we can certainly see flow within the internal carotid arteries, but we don't have any flow within the basilar artery. So is this a large basilar artery occlusion? Well, we might expect to see more areas of diffusion restriction, but we don't. We just have a small, subtle area within that left occipital lobe. So when we scroll up a little further, we can see that we've got this interesting vessel that essentially connects from the internal carotid artery back to the basilar apex, and this is a persistent trigeminal artery. Why is it important to recognize this anatomic variant, and why is it relevant in this case? Well, most occipital lobe infarcts would be considered a problem with the posterior circulation related to an underlying abnormality potentially within the vertebral arteries. But in this case, since the vascular supply of the occipital lobes is from the persistent trigeminal artery, we really need to be interrogating the internal carotid arteries in the neck to evaluate for an underlying thromboembolic source. Let's take a look at this companion case. This is a man in his 70s who has coronary artery disease and hyperlipidemia, who presents with acute onset of dizziness and ataxia. On physical exam, he has neglect and a visual field deficit. He was given IVTPA and subsequently developed a worsening headache. We notice on this follow-up PET-CT that he has a region of hemorrhage within the right occipital lobe, suspicious for hemorrhagic transformation of a PCA distribution infarct. On subsequent MRI, we can see here that there's diffusion restriction within the right occipital lobe. On MRA, notice here how the posterior cerebral artery arises directly from the internal carotid artery rather than from the basilar artery. This is the so-called fetal posterior cerebral artery. It's important for us as radiologists to recognize these anterior-posterior anatomic variants, which may have vascular implications related to potential sources of stroke, allowing us to focus our attention on the appropriate supplying vessel within the neck. Our next patient is a man in his 60s who presents with acute confusion with a right superior quadrant defect, and he's unable to read any words, but he can recognize some letters. When presented with the word room, he spells it out as B005. So when we're trying to localize the lesion in this patient, we're thinking about potentially those fibers within the left temporal lobe, within Meyer's loop, or potentially along the inferior aspect of the occipital lobe. When we take a look at the MRI, we see that this patient has a region of diffusion restriction in the left anteromedial temporal lobe in the fusiform gyrus, within that anteromedial aspect of the posterior cerebral artery territory. Interestingly, infarcts in the fusiform gyrus manifest with higher cortical processing problems, when on the left, as we see in our case, patients can have alexia, and when on the right, patients can have prosopagnosia, or the inability to recognize faces. Posterior circulation infarcts tend to present with visual field deficits, as we've seen in the last few examples, and if they involve the thalamus, they may also affect sensory pathways and arousal. In this patient who's presenting with decreased alertness, we can see that we've got bilateral paramedian infarcts within the medial thalami in a characteristic vascular territory that localizes to the artery of Percheron. This is a known anatomic variant that results in a common trunk from the top of the basilar that results in bilateral vascular supply of the thalamus. In summary, we've reviewed a number of patient presentations and have learned that there are important cortical signs that can help us differentiate between large vessel and small vessel infarcts. The main cortical sign within the left hemisphere is language, and the cortical sign in the right hemisphere is attention. Patients with large vessel occlusions often present with eye deviation towards the hemisphere affected by stroke. I've compiled the summary graphic that highlights the primary presenting symptoms based on the vascular territory affected. Here are some important takeaway points. Large vessel left middle cerebral artery circulation infarcts often present with aphasia. Look for an M1 occlusion if the patient has global aphasia, in addition to motor weakness and sensory deficits. Look for a superior division occlusion if the patient has an expressive aphasia affecting Broca's area, or an inferior division occlusion if the patient has a receptive aphasia affecting Wernicke's area. If the patient has neglect, take a look at the right M1 segment, as well as the inferior and superior divisions. If the patient has isolated motor or sensory deficits and the absence of a cortical sign, think about a small vessel infarct potentially involving the internal capsule or the thalamus. For all anterior circulation infarcts, take a look at the carotid arteries in the neck to evaluate for a potential source of thromboembolism. Posterior cerebral artery distribution infarcts often present with a visual field cut within the side contralateral to the visual deficit. If the thalamus is also involved, the patient may have additional sensory deficits and somnolence. In most patients with a PCA distribution infarct, you'll want to interrogate the vertebral arteries in the neck to evaluate for a potential thromboembolic source. Look for common anatomic variants, though, like a fetal posterior cerebral artery or a persistent trigeminal artery that can serve as an alternate explanation for the source of stroke. I'd like to highlight several references that I used in my talk today, including the links to the YouTube videos of those patients with aphasia. I'd like to thank you for your time and attention, and I hope that you enjoy the rest of the meeting.
What a fantastic start to our new season of Friday live streams. Tabby did an amazing job of putting the clinical into clinical radiology. If you enjoyed that talk, well, Tabby has a brand new lecture featuring at Radiopedia 2023 titled Neck CT Search Patterns and Check Areas. And in fact, that's one of 6 brand new head and neck lectures that we'll have at the conference. Well, that's all for now. Before I go, don't forget to check out the conference registration page. All the details and different options of how you can register are listed there. And don't forget to submit your abstracts for the R posters. The deadline is the 28th of February, and as I said, we want as many of you to be involved as possible. I'll see you again soon. Bye-bye.